Welcome to the Explainer. So today, we're exploring a pretty monumental shift in eye care, and we're going to do that by navigating the brand new TFOS DEWS 3 diagnostic methodology. Look, if you regularly treat dry eye patients, you already know exactly how complex this landscape can be, right? Well, this explainer is designed to put you firmly in the clinical driver's seat. We're going to take you step by step through this newly updated diagnostic funnel, straight into the most effective, comprehensive treatment strategies available out there today.
Okay, let's dive right in. Here's our roadmap. We'll start broad by redefining the disease, move on through screening with the OSDI-6, identify those key markers of homeostatic loss, blueprint the autonomous disease drivers, and finally arrive at comprehensive treatment approaches. All right, Section 1, Redefining Dry Eye Disease, the New Landscape. The 2025 TFOS DEWS 3 report fundamentally shifts how we really need to conceptualize this condition. So the DEWSI report updates the definition pretty significantly. It says, and I'm quoting here, dry eye is a multifactorial symptomatic disease characterized by a loss of homeostasis of the tear film and/or ocular surface. Now, what you really need to take away from this is that one word, symptomatic. The updated definition literally requires ocular symptoms for a diagnosis, and by explicitly calling it a disease, the report firmly moves us away from treating dry eye as just a syndrome. It's a complex, multifactorial disease, and it's affected by genetics, lifestyle, and a whole bunch of environmental factors. Now, a major addition to this definition is the phrase loss of homeostasis, basically the breakdown of stability and balance. DEWS 3 updates our recognition that this loss applies not just within the tear film itself, but across the entire ocular surface microenvironment. And honestly, understanding this core concept of homeostatic loss is absolutely crucial before we can even start looking for the physical, microscopic markers of the disease in the clinic. Moving right along to Section 2, Screening with the OSDI-6, the filter. This is where we start building our diagnostic funnel, and it acts as the critical gatekeeper for your practice. Now, what's really interesting about this slide is how efficiently the OSDI-6 filters your patients. The DEWS 3 report now recommends the shortened Ocular Surface Disease Index 6. Unlike the older 12-item questionnaire that only looked at the previous week, this streamlined 6-question survey evaluates symptoms over the entire past month. And your primary filter here is a critical diagnostic cutoff score of 4 or higher. If your patient scores a 4, 5, or more, they've officially crossed the threshold for subjective symptoms of dry eye. So, picture this. The patient is sitting right there in your chair, and boom, they've just scored a 4 on the OSDI-6. So, what happens next? How do we actually make that critical transition from just logging these subjective symptoms to finding hard, objective clinical signs? And that brings us to Section 3, Markers of Homeostatic Loss, the microscopic view. This is the absolute climax of the diagnostic funnel. To successfully transition from subjective screening straight into an objective diagnosis, you've got to rely on a very specific Boolean logic that DEWS 3 outlines. Step 1, you must find a positive tear film marker. That means tear film instability or hyperosmolarity. Step 2, you must pair that finding with comprehensive ocular surface staining. So it's an or followed by an and. You need one tear film marker, and you absolutely must observe surface staining of the cornea, conjunctiva, and lid margin. And this brilliantly illustrates the exact clinical cutoff values you need to memorize to objectively diagnose that loss of homeostasis. Let's break it down. For tear film markers, a non-invasive breakup time of less than 10 seconds or a fluorescein breakup time of less than 5 seconds indicates instability. For osmolarity, you are looking for 308 milliosmoles per liter or higher in the more severe eye. Then, for ocular surface staining, the cutoffs are greater than 5 punctate spots on the cornea, greater than 9 spots on the conjunctiva, or lid margin staining that's at least 2 millimeters long and 25% wide. Hitting these precise microscopic markers, that's what confirms your diagnosis. Okay, once those markers confirm the diagnosis, we move to Section 4, Identifying Autonomous Disease Drivers, the blueprint. There's a massive contrast here between the old paradigm, the one where we just classified dry eye on a simple linear scale of mild or severe, and this new DEWS 3 paradigm. Now, it's all about identifying exactly which of the 9 autonomous drivers are active. Dr. Joseph Tober, who actually co-authored the report's management and therapy section, points out that these drivers operate totally autonomously and at differing severities in literally every single patient. You could easily have a patient with massive inflammation but almost no cellular damage, right alongside a patient with minimal inflammation but severe corneal staining. Because of that, it is virtually impossible to just label a case mild or severe anymore. You have to blueprint exactly what is going wrong.
Which leads us perfectly into our final section, comprehensive treatment approaches, the action phase. This is where our meticulous diagnostic methodology dictates successful strategy. Dr. Tauber uses this fantastic car analogy to vividly explain this concept to his patients. Just think about it. Refueling an empty gas tank won't fix a flat tire. If you fix one but ignore the other, that car still isn't going anywhere. And this perfectly illustrates why the old method of stepwise therapy escalation, starting treatment A, waiting a few months, and then adding treatment B if it fails, why that rarely ever succeeds. The central lesson of DEWS 3 is that you cannot leave even a single active driver untreated. You have to treat every active driver contributing to the patient's signs and symptoms simultaneously, the whole shebang. So, what does this look like as an actual therapeutic solution? Well, when you're looking for a treatment that can hit everything at once, serum tears really stand out in the DWS-3 report as a true multi-driver solution. Because serum contains a massive litany of growth factors and regenerative components, it tackles multiple pathophysiologic pathways at the exact same time. It addresses tear insufficiency by improving quantity and quality, it promotes the healing of that corneal staining, it quells inflammation, and incredibly, it even addresses neural dysfunction, which honestly is something very few other interventions can manage. So the crucial point is, does it actually work out there in the real world? Well, the data says yes, for sure. In a massive, yet-to-be-published study by Vital Tears, evaluating over 1,000 patients, a whopping 79% of patients reported symptom improvement after just 30 days of serum tear use. In fact, nearly 60% experienced a clinically meaningful OSDI gain of more than 15 points. The results were actually so strong that researchers had to literally create a new category for significant OSDI improvement to account for the nearly 30% of patients who saw a greater than 25-point gain. That is huge. So we've covered the complete journey today, from the new definition of dry eye through the OSDI-6 screening, down to pinpointing the exact microscopic homeostatic markers, and finally utilizing comprehensive multi-driver treatments like serum tears. So I'll leave you with this. Are you ready to revamp your diagnostic funnel and treat the whole vehicle rather than just changing a single tire? Because by embracing this DUS-3 framework, you can offer your patients the individualized, mechanism-directed treatments that actually get results. Thanks so much for joining me on this explainer, and I really hope this empowers you in your daily practice.